All right, well, I would like, if I may, to go ahead and introduce our speaker for this evening. And of course, first I'll just introduce myself. I'm Rebekah Bernard. I'm a family physician, and I'm the current president of the Collier County Medical Society. And I'm being joined tonight for a webinar by our CCMS member, Rebekah Witherell. She is an infectious disease specialist who is also board certified in internal medicine as well as infectious disease. Dr. Witherell works for NCH physician group, and she works with the residents as well in the internal medicine program. She attended St. George's University for medical school, and she completed her internship, residency, and fellowship at Ascension St. John in Detroit, and she's been with us here in Naples and Collier County for about a year. So we welcome her, and thank you so much. I will hand it over to Dr. Witherell.
Oh, thank you very much, Rebekah. So I appreciate that warm welcome, and I look forward to sharing some information with you folks tonight. And if you have questions, I'll do my best to answer them. Obviously, the thing about COVID that we all know is that it's an ever-changing myriad of different data coming at us, and trying to stay on top of all of that can be quite challenging. So I do my best to parse through all of the information to give you guys the most up-to-date and helpful information while trying to weed out some of the things that are not as helpful. So I'll go ahead and pull up my slides here to kind of get things kicked off. So I want to start with an update, just looking at the updates in our state and what's been happening. So we all know that COVID continues to rage on, and we're having lots of cases on a daily basis. The good news is that we're not in the shape that we were in a couple of months ago, but we do remain at risk for ongoing spikes in cases, especially as we were talking about as snowbirds start coming down here in the wintertime, and we're having a lot of mixing of different groups of people and people who really are getting frustrated with being in social isolation for so long. Obviously, it's difficult. And so it's going to be a difficult winter, I think, for all of us as we start seeing more people coming into town and more interactions happening between individuals that may not necessarily be done in the safest way. So keep in mind that the dashboard is always available for us to look at for the state and for our county. So it's giving us the most up-to-date information. I do like to point out that when you look at the dashboard, when you're looking at the resident deaths by date of death, keep in mind that there's a lag there because that requires that the death certificate be completely filled out and processed. So there's usually some lag of at least 1 week when you're looking at that particular chart. So when we look more specifically at Collier County, what we see is that we've been having a pretty steady amount of cases over the last 1 month. And so I wanted to take a look at the bigger picture because I think that knowing kind of what's been happening over more than 1 month is helpful, especially when we're talking about where our spike in cases actually occurred. So when we were in July, that was really where we were hit the hardest, and we were most concerned about overwhelming our healthcare system and our resources and the inpatient side. At this point in time, we do not remain at risk for that, but obviously we have the potential threat of those resources being overrun again if more people come into town and are not practicing safe social distancing and hand hygiene and mask wearing. So we are doing okay right now, and we can be proud of ourselves in the education that we've been providing to our patients and to their families and to our community. But we need to continue to do that as we get some of that fatigue from being cooped up, as we were just talking about during our social visit. So as I move through the presentation, I had some folks that sent in questions that I'll do my best to kind of answer. And then if there's additional questions, I'd be happy to do my best to answer those at the end. So looking kind of the testing that we have available to us, there's been a big swing in things. You know, rapid antigen testing, it got a really negative reputation at the beginning of all of this because it truly it does not have the same sensitivity as PCR. And so there is a place for rapid antigen testing and there's a place for PCR testing. And so the way that I like to think of it is the way that I think of influenza testing. If I need a rapid test and I'm testing many people and I want a quick turnaround, and I know that the COVID test PCR is going to be taking a longer period of time to get test results back, or if I don't have the ability to even do the PCR test quickly, the antigen test is a good starting point. So it's best performed early in the stage of infection because that's generally when your viral load is going to be the highest. And so you're going to get the most reliable test results at that point in time. So as far as when we're talking about falsely negative results. So it can be helpful when it's positive. When it's negative and you have a high suspicion, the reality is you do need to go on to PCR testing, but it's a good starting point. It's less expensive, it's a faster turnaround, and it's a less invasive way of obtaining the sample. So your patients will appreciate that too. So it can be used when you're testing high-risk groups of people, especially when we start talking about in healthcare settings and in nursing homes or prisons or schools where there's large groups of people all together. Antigen testing is a really good way of doing things quickly and affordably. So it also allows you the ability to test more than one point in time. And so that increases your sensitivity, obviously, if you're able to test more than one time per person. So it's really helpful with infection control measures when we're talking about looking at large groups of people. It's not as good when we're looking at individual people that have symptoms. So with regard to FDA testing, there are many tests available right now and they run the gamut. So if you have specific questions about a particular test, my recommendation is to actually go to the FDA's website. They have it very well organized and it's set up so that you can look and find the test by its name and you can see if it has an emergency authorization or if it does not, and whether it's a recommended test or if it's a test that's been pulled off the market. Because there have been some problems with bootleg tests as well. So I recommend any specific questions about a test and whether or not it's a useful test or not, those I would recommend looking right at the FDA website. So once again, going back to our PCR test, we're talking about when you're talking about screening asymptomatic people, this is going to be the most sensitive mechanism. So it is the recommended or preferred method for testing when it's available. So that means that you have to take into consideration your turnaround time as well as your testing kit availability. So when there's a prolonged turnaround time on PCR testing, you'd be better off going with the point of care test that you're going to get back in real time, because that at least gives you a jumping off point. So when we're talking once again about congregate care, so when we're talking about large groups of people, we talked about doing those tests as a point of care test at different points in time can be the most helpful. So that's what's recommended for those specific groups of people. In an outbreak setting, you need to be concerned about people who have a false negative test with the antigen test. So you're going to want to confirm a negative test with a PCR. So those are the recommendations as they're currently put out by both CDC and FDA. Now let's move a little bit into what are we doing with plasma these days? So it's been a very hot topic and there's been a lot of money spent on advertising to get people to donate plasma, and have a lot of people ask me if they are a candidate to donate and they want to help. And there's a lot of good-souled, good-spirited people out there who really want to be able to help. So at this point, we're using convalescent plasma that's been collected from someone who has developed the disease, who is known to be positive, and then developed the antibodies. Now, this is the acellular component of blood, and that so it contains multiple different kinds of antibodies. So this is not a purified antibody, it's all the different antibodies that the person that's donating has. So these are thought to exhibit an antiviral effect by suppressing the viral replication. So these are most helpful when the patient has not developed their own humoral response. So what we're talking about is essentially one of two situations. Either it's very early in the patient's disease process and they haven't been able to have the time to mount an appropriate response, so they've only been sick for a day or two, or they have a problem where they have non-functioning or ill-functioning immune system would be the second case. So if you have a patient who is on chemotherapy or is immunocompromised for some other reason, then disease-modifying medications for rheumatoid arthritis or Crohn's disease or something like this, we need to take into account patients that don't have a good humoral immunity response. Those patients may also benefit. So if you have a patient who's been ill for a week and they're still spiking fevers, that's an indication that their body may be having trouble controlling the virus itself. And so I think knowing where your patient is within the scope of their illness is very important. So discerning when they had their first symptoms becomes really important. We know that patients who are able to control their viremia on their own don't seem to have a benefit from the convalescent plasma, and that they tend to do pretty well with controlling the virus quickly. Their fevers go away pretty quickly. We know that around day 8 to 10, that's when people tend to have a problem with severe hypoxia, and they tend to take a downward turn if that's going to be a problem for them. And it seems to be more related to that when the immune system is really ramping up its response and you're getting a lot more of the immunomodulation and inflammatory problem. So once you get to that stage of illness, the plasma and the antibodies themselves don't appear to add anything. They don't have a benefit at that point. So there are ongoing studies with plasma, and Mayo put out a really large study where they're ongoing, looking at 60,000 patients. And at this point, there's no clear benefit. So the good news is with that study, they studied a lot of people and there was also no clear harms. There were very few harms within the study, and they were less than 1% of the cohort that was tested. So there are no true randomized controlled studies looking at convalescent plasma to date that have been published. So we still are kind of in the dark on this, but using the data that we do have from Mayo and other sources, and using our understanding of pathophysiology, we know that, if there's no harm, we may continue to use it, but keep in mind that if it's late in the disease and the patient is having more of an immunomodulatory effect, it's probably not going to be very helpful. Or if the patient is going to have a benefit, it's probably going to be in a patient who is either early in disease or has immunocompromise. So I included one of the studies here that recently came out, and it was a small study. This study in particular looks at severely ill patients. So once again, these are patients that are likely having a problem controlling their viremia. And so they had life-threatening COVID and they were on a ventilator and they were in the ICU. So they found that these patients actually had a survival improvement, and they did better. So this is one of the reasons in the patients who are severely ill in the ICU, we are still using plasma. This data is promising that it would have a positive effect for those patients. And as I mentioned, we've found very little harm from using convalescent plasma. So now talking more about monoclonal antibodies, now we're talking about a focused response. Instead of the broad plasma with many different kinds of antibodies, we're talking about a laboratory-made version of proteins that's going to be produced, and we're going to focus that to a specific virus, in this case, the SARS-CoV-2 virus, COVID-19. So we want to have neutralizing antibodies, and in this case, we're choosing monoclonal, and we're proliferating those monoclonal antibodies. The idea is that they're going to bind to a portion of the virus so that it cannot attach to the cell and it's not able to enter the cell to start its replication process, and thereby cutting off the viral replication process before it even begins. So they're intended to provide immediate antiviral effect and activity, and it should last about 3 weeks, 2 to 3 weeks. And that's because that's approximately how long the antibodies are going to stay intact and circulating within the immune system. So at this point, there is not any published data to support the use of monoclonal antibodies. However, there are ongoing trials, and this research is promising, but there's just not data yet. So that's one of the things you're going to have to stay tuned for. So the two big companies that we're hearing a lot about right now, one is Regeneron, and they are working with the with NIAD, NIAD. So they got a lot of publicity recently due to President Trump's recent discussion about them and receiving one of their products. So their product is designed to bind 2 points on the SARS-CoV-2 protein and do exactly what we just talked about. It's going to block entry of the virus into the cell to prevent replication. So this is an ongoing study that is happening right now. It's looking at household contacts. So what they're doing is, for someone who has a positive test, they're going to their household contacts that have not tested positive yet, and they're asking if they'd like to participate in the study, and they're giving them the antibody to see if that will prevent them from getting the disease and to see if it will prevent them from getting severe disease. So they'll be looking at those endpoints. So it'll be very interesting to see how that comes out. And keep in mind that these antibodies are not inexpensive either. So that's another thing when we're talking about severity of disease. Obviously, we'll have to look at number needed to treat and the cost to see if there's true benefit. And we're not to that point yet. The other company that has very promising research is Eli Lilly. They're also working with NIAD, and their product is a monoclonal antibody that is recovered from a COVID-19 patient. And they are using this to prevent the infection among people in high-risk exposure groups. So they're looking at people who are residing or working in skilled nursing facilities or assisted living facilities. And so their focus is a little bit different than the other group. And they're looking at prevention and post-exposure prophylaxis in the group of people that are not necessarily living with one another, but are in close contact at many points of time during the day. So once again, that is an ongoing study. There's enrollment still going at this time. These are new studies, and there is not data yet to be able to answer whether they have a true efficacy or not. So a lot of controversy has surrounded how do we actually treat this virus? How do we help our patients once they get diagnosed? And we still have very limited resources for helping people to get well. So the biggest thing that we're going to continue to do is isolation of patients, which is really hard on them and really hard on their family members. But it's the best thing that we know to help stop the spread of disease. So in conjunction with that, we have contact tracing and testing, obviously trying to limit the spread of disease. And we know that the data that has come out at this point, looking at antiviral medications, I generally cite remdesivir because it is the most well-known medication. There is no benefit to using antiviral medications in mild to moderate disease. So essentially, if your patient is not in the hospital, they have mild to moderate disease, and they're not hypoxic, they're at home, they're comfortable, they're taking supportive measures and self-isolating, those patients will not have a benefit from the antiviral medication. It's just another expense and another potential for side effects. So we would not recommend giving that medication to those patients. We're recommending supportive care and symptomatic management at home. When someone is inside the hospital and they have moderate to severe disease, so we're talking about the patient who now has hypoxia, to qualify for the medications, generally they need to be hypoxic with the oxygen saturation of less than 90% on room air. Some studies did look at considering moderate disease at less than 94% saturation on room air. But in all of these patients, we definitely are going to be isolating them. We try to recommend self-proning, and that has shown to help patients have better oxygenation. Once again, we continue with supportive measures, whether that's supplemental oxygen, supplemental supportive care, and antipyretic agents, as well as nasal sprays and ways of keeping the nose open and free of any debris to allow for nice deep breaths, and trying to allow minimal coughing at night so the patients are able to sleep, but allowing them to cough if they do have a productive cough, especially during the daytime. So we don't want to completely suppress the cough and cause additional problems or secondary bacterial issues, but at the same time, a ongoing cough for these patients, when especially the dry cough a lot of them have, it does tend to lead to more episodes of hypoxia, which are more dangerous than the suppression of the cough itself. So what are we doing for these patients with severe disease? Well, we're recommending dexamethasone. This has been studied, and we have seen the benefit of steroids. Initially, when we all started hearing about COVID, there was a lot of discrepancies about whether or not steroids would be helpful. But now we have this large study that shows us that using the 6 milligrams of dexamethasone once a day for 10 days has shown a mortality benefit in patients who were hypoxic. So once again, that medication is helpful in patients who are hypoxic, but in patients who were not hypoxic, who had mild disease or were able to be maintained at home, those patients with mild disease actually had more harm from the steroids than from supportive measures alone. So we only want to use it when we're going to have the benefit, which is in the patients who are hypoxic. In addition to dexamethasone, hypoxic patients have shown a benefit from remdesivir. There was not a mortality benefit with remdesivir, but there is a shortening of the course of illness. So it shortened patients' hospitalization as well as their number of symptomatic days. So we do see an improvement from remdesivir. The study was ended a bit early due to that improvement, and so there was no ability to demonstrate if there was a mortality benefit or not. So that's something we can't use the claim for mortality benefit, unfortunately, but we do at least know that we're getting a morbidity benefit from using that medication. Remdesivir as an antiviral, it does help earlier in disease rather than later. So once again, knowing when your patient got sick is really helpful. If they're within their first week of illness, that's when remdesivir is going to be the most helpful. If they are to the point where they are in the inflammatory stages of the disease and they're having very high inflammatory markers and hypoxic events, those patients will not get as much benefit from the remdesivir because the issue at that point is not viremia. Examples of times where you may still want to use remdesivir for a patient who's been sick for a long time would be those patients that we talked about were not able to control their viremia. So they're still having a lot of fatigue and fevers, and they're having symptoms of viremia itself as opposed to inflammatory symptoms. I would still recommend using the remdesivir in that group of people or an immunocompromised host, even later in disease, because they have trouble controlling the viremia, and that's what the remdesivir is really useful for. Actemra is not something we use a lot because that has not been, it has not shown any mortality benefit. But where it is being used right now is late in disease. So after a week, when we talk about this immunomodulatory problem, that's when Actemra can be helpful. So when we talk about IL-6 inhibition being important, this is one of the medications that really can help with that. So we see it being used in patients who are having an HLH-like syndrome or cytokine storm, because it can help to control that better so that they're better able to modulate their immune response and not have a hyperactive response that leads to them going into ARDS and having instability. Now, there is something called the MARIK protocol, and I believe it's on my next slide here. So the MARIK protocol is something that was developed at one of the university medical schools and university hospitals, and it's from Eastern Virginia. Now, it's gotten a lot of publicity because as physicians, we always want to be able to do something for our patients. And so being in this position where we don't have many options is very frustrating to all of us. So this MARIK protocol has a lot of people excited because it allows them to be able to feel that they're doing something. Now, a lot of these things don't have terrible side effects. So, for example, if you look under the prophylaxis section with vitamin C, zinc, melatonin, vitamin D, and famotidine, or in the mildly symptomatic category, it's a pretty similar group of medications. Those don't have a lot of harms. So, whether they have some placebo effect or whether that's a effect for us to feel better, they don't have a lot of harms. So some people are using them, but keep in mind that this has not been proven by evidence to be helpful. So that's where I'll leave it. But this is a protocol that exists that is being used in many places. I know some physicians are using this and picking and choosing what they like. And honestly, there's no evidence no matter how you slice it. So if you want to pick and choose which of these things you like, that is a reasonable thing to do. There's just not a lot of evidence on supplements. And so I'll be talking about that in a couple of slides. So we'll touch on our good old friend hydroxychloroquine. It's significantly fallen out of favor. And here's one of the studies. There have been many studies, but here's one of the studies that was a good size study with 821 asymptomatic people. This was looking at prevention of disease, right? So post-exposure prophylaxis. Now, what they found was that in the groups that there were more side effects from the hydroxychloroquine than from the placebo, which is what we would expect. And unfortunately, we didn't see any benefits of alteration of symptoms or any decreased incidence of COVID-19 in patients who received the medication. So essentially, hydroxychloroquine, for all the things we got excited about back 6 months ago, it really has not panned out. It's not appearing to be helpful for prophylaxis or for therapy. And with the risks that it has, in addition to the fact that when we're using it inappropriately, we're taking it away from the other patients who do need it for their chronic conditions, I don't think that there's any leg to stand on at this point in time for hydroxychloroquine use. So I'll talk a little bit about supplements because it's been a big issue, a big hot topic for a lot of patients. They're wanting to be able to take something and they want to prevent getting sick and they want to know how to do that. And I'm sure in the primary care office, that's happening a lot. So vitamin D has gotten a lot of attention. And I think we like to study vitamin D with lots of different diseases. But what we found so far with COVID-19 is that there's a correlation between adequate vitamin D levels and less severe disease, as well as lower rates of disease in vitamin D deficient patients. So in a nutshell, I included some specific data here at the bottom of the slide, talking about patients who were adequate versus deficient, but we're talking, this is for prophylaxis, and this is for making sure patients don't get severe disease if they do get sick. So this is in a healthy patient. They're looking at the benefit of this vitamin D. There's no studies that looked at giving vitamin D after the patient was already sick and if that made a difference in their long-term outcomes. We know that patients who have replete vitamin D throughout the course of their illness do better, but that's a correlation. So there's still ongoing studies looking at if giving the therapy during illness gives a significant difference, or is it just that patients who have a higher vitamin D level for whatever reason do better for unknown reasons. And we don't have the causal section here, but the idea is that giving vitamin D, so recommending vitamin D to our general population is probably a good idea for people who are deficient. And that is, once again, for all kinds of reasons, we know that having a low vitamin D level is less than ideal. So recommending that people supplement their vitamin D to get to a sufficient level, so above 30 is where we basically want our healthy population to be, to try and help protect them against severe disease and hopefully protect them against getting the disease in the first place. So vitamin C is another vitamin that's gotten a lot of attention, and it's so readily available over the counter, and there's already the idea of vitamin C helping to protect against other viral illnesses, that people get very excited about taking that. So it's a water-soluble vitamin. It's inexpensive for people to get at the drugstore as far as the oral formulation. And we also have the IV formulation within the hospital. So the benefits at this point are theoretical. There's thought to be a beneficial effect for patients with critical illness, and that has to do with the fact that it acts as an antioxidant and a free radical scavenger. So we like it because it has anti-inflammatory properties, it influences cellular immunity, increases vascular integrity, and it's also a cofactor. So there's lots of really great things about vitamin C. And you can see in the chart that IV vitamin C is a very different beast than oral vitamin C. So with that being said, if your patient wants to take vitamin C, well, they're certainly not going to be hurt by taking it. It can cause some GI upset or cramping, and they can stop if that happens. But generally speaking, oral vitamin C is not a problem for patients, but it also needs to be clear that vitamin C orally is not in any way, shape, or form equivalent to IV vitamin C when we're talking about bioavailability levels. So when we're talking about the studies that have used vitamin C and that are ongoing and looking at the benefit, because there does appear to be some benefit from having adequate levels of vitamin C. Those studies were done using IV vitamin C within the hospital on sick patients. There's not data looking at PO vitamin C in the outpatient setting because the levels are very, very low. When we talk about what do we do after a patient is exposed or diagnosed, and how long are we supposed to leave them in isolation? It's a hard thing to do. They're off work, they're missing out on their livelihood, and it can be really difficult to have to tell someone that they have to isolate. But at this point, the good news is that the isolation recommendations have gained some clarity, and I feel that they're a little more manageable than they were back a few months ago. So at this point in time, you need to have a fever-free interval of 24 hours without any medication to stop the fever. So no Tylenol, no NSAIDs. And in addition to that, you need to have either improvement or resolution of the symptoms. So some people we know are going to have a persistent cough for a really long time, and we're not going to leave them in isolation the entire time they have a cough, but they need to at least be getting better. They may have hypoxia for a long time, but they need to at least be stabilizing and getting better. And then that would qualify them to move down this path of getting their isolation removed. So the number of days becomes important here once again. So knowing that disease onset date, once again, here it is important. So with mild to moderate disease, 10 days from their original symptom, that first symptom day is day number 1. So once you get 10 days from there and they meet the other 2 qualifiers, no fever for 24 hours without an antipyretic, and they have improvement or resolution of their other symptoms, they can come out of isolation. Now, if they have severe disease, so they're in the hospital, they're hypoxic, they require some of those other medicines we talked about, or they're immunocompromised, or there's a few other caveats. Those are the main ones. Those patients, we're recommending that they stay in isolation for 20 days because as a person has prolonged viral shedding, if they had difficulty controlling their viremia, if they receive steroids, that can also inhibit their ability to control their viremia. So we think that they're having additional shedding time or prolonged shedding. And for that reason, we're extending their isolation to 20 days plus the caveats of the afebrile for 24 hours and the improvement of symptoms. So at this point in time, this is a symptoms-based strategy, and most places are moving toward a symptom-based strategy. The place where I still see testing-based strategy being sort of applied is nursing homes. When we're trying to discharge patients from the hospital to a nursing home, I'm still seeing a testing-based strategy, but even that is being modified a little bit more. So as we're learning more about the illness and we know about this issue of prolonged positive testing, even in the setting of dead viral particles or non-infectious viral particles being released, it's become clear that the testing-based strategy may not be as useful, as patients can be shedding viral particles for up to 3 months, but there haven't been any cases reported of someone with prolonged viral shedding or viral particle shedding leading to a case through exposure. So that's why the isolation recommendations have changed. So once again, if the patient is having symptoms, you can use the symptom-based strategy. If the patient never had symptoms in the first place, you're going to go with the 10 days from the test will be how long they should isolate, because at that point you're not sure if they had an exposure 2 days ago or they had exposure 3 weeks ago. No way to know. So for those patients, we are recommending a 10-day isolation. Now, what about our staff and our patients? How are we going to help those people? So we need to talk about universal masking and goggles for our staff. So masking obviously has been a very political issue in our community, but when it comes to our offices and our staff, we want to protect ourselves and the people who work for us. They expect that we're going to protect them. And that's our job and our duty to do those things. So all of our employees should be masked and they should be provided with eye protection. I know it's tough. The social distancing in the break room, I think, is one of the most difficult things for staff members to wrap their head around. They're very willing to accept masks and goggles in the rooms, but it's really hard to get them to socially distance in the lunchroom. But it's very important because, as we talked about, there can be asymptomatic cases, and we're still learning about how much the viral shedding those patients have, and we don't want our staff members making each other sick either. So making sure to social distance in the break room, whether that means staggering breaks or having enough space for everyone to eat, or having some people eat in a different area. Those are all possible solutions to that issue. Now, when it comes to patients, one of the issues that I have seen a lot of personally is this issue of the mask with the valve. So the reality is, if a mask has a valve on it, it's essentially not a mask. It is of zero utility. The whole point of the mask is that it protects you a little bit, but it protects everybody else a lot. But with a valve, you're losing that efficacy. So in our office, what we have done is we have started telling patients that they cannot use masks that have a valve. We will allow cloth masks, but we will not allow masks with a valve. And you'll probably notice that a lot of airlines and airports are also taking that stance, and it's for this reason, because a mask with a valve is equivalent to me breathing out with no mask at all and just breathing all over people. So we do continue to remind our patients that they need to wear the appropriate type of mask for it to be useful to themselves and to others as well. Now, when our staff are working with patients who are a suspected case, that's when we would recommend the N95 or a respirator and a gown for the interaction. Now, there's going to be asymptomatic cases, and that's why we do universal masking and goggles. And I will tell you that from the study that I personally have been working on at the hospital, we found that this universal masking policy works quite well. And even whether it's the nurses and the staff who work on the COVID unit, or whether it's the nurses and staff who work on the non-COVID floors, or whether it's our folks who don't have any patient interaction at all, our rates were consistent across those different platforms. And so we see the effect of universal masking keeping our employees and our coworkers safe. So this is the main reason that we want to take part in perpetuating that education and making sure people are using the right PPE for the right type of interaction. Another thing that helps in the office is increased cleaning. So having a schedule that allows for more frequent disinfection of surfaces, and that includes areas such as door handles, bathroom handles, flat counter spaces within the rooms. Basically, any horizontal surface should be wiped down. If there's a patient that has suspected COVID, those should be wiped down immediately following the patient interaction. For general in between patients, if you have enough staff to be able to do a wipe down of horizontal surfaces in the room between patients, that is ideal. If it's a high volume clinic and you don't have the time to do it between every patient, you should be setting a schedule for it to be being done as frequently as possible, because that's the best way for us to help mitigate the spread of the illness amongst our staff and our patients. Pre-screening also helps a lot because it helps us to know who we should be concerned about before we go in the room or before we let the patient come to the office. Now that we have telehealth opportunities and we have ways of getting people to be tested without coming into the office, we have a lot of opportunities to protect other patients and our staff as well. So those screening questionnaires about exposures to COVID and patient symptoms and fevers really helps us a lot. And as we move into flu season, this is going to also be incredibly important because there's going to be so much overlap with those groups of people. So knowing where your local testing centers are and being able to refer to them without having to have the patient come into your office is going to be a huge plus. So limiting additional people in the office space, I think people are starting to get used to it from the patient side, but it is a challenge for them. Obviously, some patients aren't able to come in alone. They have a caregiver, but trying to limit additional people in the waiting area and in the patient rooms, it does make a difference. And so we do want to try to limit the exposures that we're creating for folks. And of course, frequent hand washing goes without saying. We know that the big three for preventing disease are masking, social distancing, and hand washing. So we should be washing our hands in the room, out of the room every single time. But what about our patients? They're not washing their hands that often. We know that if you put stations for people to have the opportunity to wash their hands, a lot of patients, not all of them, but a lot of patients will seize those opportunities. So placing a stand where they have hand sanitizer when they enter into the office, into the waiting area, or when they're leaving from their checkout, or both of those places ideally, really allows patients to feel safe and to be participating in the general process of limiting disease spread within the office. So a lot of patients really appreciate that one simple thing of having that hand washing or hand sanitizer station for them to be able to get a quick dollop of hand sanitizer from. Now, some people will have the issue where they don't feel comfortable wearing a mask. They feel that they can't breathe well. There's anxieties about it. There are a lot of different issues that come up. Now, there was some discussion about shields being used instead of masks and how does that work? Well, shields do help. They're not an absolutely zero utility, but the reality is that they are no substitute for a mask. The problem with shields is that they have a lot of open space, especially around the bottom. And as a result of having that open space, it still allows for small droplet particles to be inhaled up from the bottom or to come in from the sides. So shields are very helpful for protection from splashes or large droplets, for example, when someone is coughing. But for the smaller particles, they don't help. And we have numerous reports and case studies and small case series looking at instances where there were people with masks and there were people with shields, and the people with shields were the ones that got sick and the people with masks didn't when there was an exposure to a positive COVID patient. So we have data that supports the use of masks. It shows us that shields are not the same level of protection, and therefore shields can be helpful when they're used in addition to a mask. They should not be a substitution. And in addition to those issues, we need to remind people that they need to change their mask. Using the same mask for days on end is not going to be helpful. Masks need to be, if they're cloth, they need to be laundered. And if they're throwaway or disposable masks, they need to be changed. They need to be changed preferentially once a day if they're paper masks. If they are soiled visibly at a sooner interval, or if you're breathing a lot and it gets damp, that mask should be changed sooner. As far as the shield, those shields can be cleaned, a lot of them, even the ones that are a little more flimsy. So you do want to use the bactericidal wipe, and that can be used to wipe it down after use. Anytime you're removing the mask, it should be cleaned with a bactericidal wipe. So if it's coming off your face for whatever reason, you should wipe it down before you put it back on. And getting into those habits is really what will protect everyone from contaminating themselves throughout that process. Now, as we look forward, we have vaccination, and I think a lot of us get really excited about that idea. And obviously, a lot of vaccine makers are excited too, because if you take a look here, you can see all of the different vaccine makers out there who are in different phases of study trying to rush to the finish line to get a vaccine out, because first to the gate is going to get a big chunk of change. Now, with that being said, there are two large companies that are currently working on vaccines that are in the phase 3/limited use category. And some of the ones that are in the limited use category, I will say, since you notice there's 5 of them, those are mostly in other countries, for example, in Russia. And some of their literature and their data seems a little sketchy. So I would not be comfortable recommending those vaccines for folks. We'll see what happens as things move forward. But there are 2 large companies that have ongoing studies right now from the United States point of view, and that is going to be AstraZeneca and Johnson & Johnson. Now, these are both in a phase 3/limited use capacity. Now, Johnson & Johnson, just as Rebekah was saying, just in the news, and they're on hold right now. What they're doing is actually called a pause. And so that's because someone got sick and they don't know exactly why they got sick or what they got sick with. So they're pausing the study while they investigate that further. This is a pause that is dictated from within the company. This is not from an outside source. So they're doing their due diligence and looking into this matter and seeing if this is something that needs to be addressed, or is this something where it's bad luck and someone got really sick, because that does happen. And they have 60,000 people enrolled in this study. So there are going to be people who get sick. So trying to go through and figure out what exactly happened is where they are right now. And as they get more information, then they'll decide whether or not they're going to proceed or if they're going to make adjustments in their protocol. The other company, AstraZeneca, had a problem where they had a case of transverse myelitis. And so they also had a similar issue where they did a pause and they investigated. But once again, it was one patient out of thousands and thousands of patients. So they have continued with their trial at this point and they're moving forward. So those are the 2 that I would say right now are the highest contenders for having the vaccine in a reasonable amount of time. What is reasonable is different to everyone. I would expect vaccines, truthfully, to be ready for public use and consumption. In reality, I don't foresee it happening any sooner than 6 months. And I think it will be an issue of production from there as well. So even once we do have a safe vaccine or relatively safe vaccine, there's going to be ongoing issues with production, and there's going to be issues with compliance as well. So it's going to still be a long process before we have a meaningful way of vaccinating people. I think there's a lot of hope and a lot of rushing going on right now, but when everything and the dust settles, I think it will end up being longer than people had originally thought. Along those lines, one of the things that Johnson & Johnson is really touting about their vaccine is that it's going to be a single vaccination as opposed to a series. So those are other things that, as we learn more and time has gone by, we will find out if that single vaccine is really sufficient or if a series vaccine is still required. So there's so much unknown right now surrounding the vaccines that we just have to wait and see which of these companies is going to end up producing a vaccine that has a meaningful impact and a safe impact at the same time. And when we look at other vaccinations, we have flu season knocking on our door here. And so there's been some studies that are looking at how does influenza vaccination affect COVID. And we know that patients can be sick with both viruses at the same time. It doesn't happen a lot, but it does happen. And so it is helpful, I will say from a testing point of view, that when we're doing PCR testing, that at least within the hospital, that respiratory viral panel is looking at both of those illnesses simultaneously. From a perspective of vaccination, there seems to be some shared effect or some memory effects from folks who have had doses of the influenza vaccination in the past. And it's not clear why that is, since they're not the same illness, but it appears that there is some memory immunity or invocable immunity that comes along with getting influenza shots that does have some protective effect against COVID. Now, that being said, it does not protect against COVID, but it looks like it may allow for a less severe form of illness. So there's a lot of research still going on in that area as well. And as we go into flu season, there, I'm sure, will be more studies looking at that relationship more closely, because that's a very preliminary look that we have right now, since what happened last spring was really at the tail end of flu season. So we didn't get a full look at how that was going to play out. So we'll continue to learn more about how the influenza vaccine affects COVID, but ultimately we really need to make sure that our patients who are at risk are getting the influenza vaccine, because we know that those patients are also at risk of COVID, and having both of those illnesses is going to be very devastating for people. So we need to try and protect them any way we can, and really encouraging the influenza vaccine, as we do always. We'll continue to do that this year to get people as protected as we can. Now, there's been some very interesting research that's come out just recently about MMR vaccination, and there are two global studies that are looking at that effect of MMR and how it may protect or offer some protection against COVID-19. And it appears that because of some cross reaction with the coronavirus protect other strains, that there's a cross protective effect. Once again, it is a mild effect. It is not a full-blown immunity, it doesn't appear, but it does appear to have some protection and allow for patients to have a memory response in terms of activity toward the coronavirus, even though it's a different strain. So that's pretty interesting. And they're doing some studies, as I mentioned, in a global capacity, looking at MMR vaccination and rates of COVID and severity of COVID illnesses in those areas. So more will be coming forward with that in the next few months, I'm sure, as they get more meaningful data back. So that's all that I have on my end as far as slides. So what I will do is I'm going to stop sharing my, let's see here. I'm trying to see the chat here.
I can read them to you if you don't mind. Thank you so much, Dr. Witherell. That was excellent and really comprehensive, and I learned quite a few new things. Couple questions that came up in the chat. One person has asked, has anyone studied hydroxychloroquine versus placebo versus no involvement in the study?
So the hydroxychloroquine studies that I have seen, unfortunately, have been very convoluted. And so they have not been looking at one drug versus another versus placebo versus nothing, except for in prophylaxis. So post-exposure prophylaxis, because we have lots of control, those have been looking at groups that had the big one that I had cited looks at the drug versus placebo. They didn't have a no group. But those studies did have more control and they did not show benefit. Even the larger scale prophylaxis studies, they didn't show any benefit. When we're talking about treatment, that's a very different beast. And because those patients, if you look at the hydroxychloroquine studies, those are pretty much all in combination with a myriad of other medications. And the main one that we're going to see is steroids, which we know has a mortality benefit. So that's where the hydroxychloroquine has that's how it initially got lumped in as having an effect in the first place. And I would say from the evidence, I do not believe that hydroxychloroquine has any leg to stand on as having an effect in this disease. I think that the theoretical benefit, we all got excited about it. And, we wanted something that we could use that was inexpensive, but in reality, it has not panned out. But the answer to the question is no, there's not a head-to-head placebo versus hydroxychloroquine versus nothing as a treatment.
Thank you. The other question, you mentioned that PCR is best to be done early in onset of symptoms. Is that the same for the antigen test, or I've heard it's better to wait a few days when someone's ill for that to test positive?
So for the antigen test, you want to have the highest viral load possible. That's when you're going to have the highest sensitivity. And so if a person is flagrantly symptomatic, that's when you want to test them. That's the best time. So within 1 to 2 days of the onset of illness and of having symptoms, that is the best time to test.
Okay. And as far as false negatives, we're all getting these phone calls from parents, especially with school restarting. My kid's got a runny nose and maybe a small cough, and they send them home from school. They get a negative test. What's your recommendation on whether should they go ahead and follow that 10-day self-isolation at that point based on the possible false negative, or what advice would you give us?
So I believe the school has their own protocol, so we have to follow whatever they have dictated. But the reality is we have to look at it's always about pre-test probabilities when we're looking at these antigen tests. So the same as we would say with influenza. So the reality is if the patient hasn't had any exposure and they've had low risk contact and they had a negative test, that the chances that test is probably a true negative. But if they have a high exposure rate, we know that they were exposed to somebody else. In those cases, it would be reasonable to, if possible, to go get the PCR test actually. And that if you get the negative PCR test, I would feel comfortable saying that they do not need to stay in self-isolation at that point. And that could shorten your time that you're in isolation.
That makes a lot of sense. I think Dr. Kane had a question about what is a dead viral particle. Dr. Kane, do you want to elaborate on that question, or
Yes.
do you understand what he's asking with that?
I understand what he's asking because I misspoke and because I've had a bacterial kind of day. But yeah, so I misspoke. So there's no such thing as a dead viral particle because viral illnesses are virus and they're not alive, but in their very essence. So yes, I did misspeak. So what I meant, I'll clarify, is that the viral particle itself is non-infectious. So the virus itself has to be fully intact with its virion to be able to be infective and contagious. And so once the virus has disintegrated into particles and the body has done its job, or the immunoglobulins have done their job, at that point, the virus would not be contagious. And so even though the PCR test is so sensitive that it will still pick up those particles and the DNA within the particles. And so then that's when you end up having a false positive result, in the sense that the patient is no longer contagious, but they're still shedding pieces of virus that are not going to make people sick.
Wow, I think you just kind of blew my mind with that. Like, viruses are not alive.
A lot more to that, because a virus is a virus is a virus. Now, if there's antibodies attached to it, so it's already handcuffed, or if there's something lacking from that virus particle that is infectious, then this is exciting research that we're just scratching the surface. We have no clue what we're talking about.
That is fair.
But they talk about flu vaccine and they'll say it's a killed or deactivated virus. So I guess that's kind of a misnomer then, in a way.
Yeah, we call it killed, but it's inactivated.
This is good information. Thank you. That's why you guys are the specialists. This is good. I see a question that says, what about serological tests in Cooks County? Whoever put that in its iPhone, would you like to elaborate on what you're saying. I says I got a 19-year-old long hauler, I think it says. However, serological tests and antibodies, and the patient appears to have myocarditis.
So speaking about PCR tests and serologic tests. So serologic tests are very interesting, and we're still learning about those. And so that I mentioned a little bit about my own research. That is what we are looking at specifically, is antibody responses and exposure rates and things like that. So that's where the serologic testing comes in. So the utility for serologic testing is very muddy. So I see here you added, okay, PCR and serologic negative ×3. So what happens is everybody produces antibodies differently. And so 19-year-olds generally have a pretty robust immune response to things, but not all of them do. We know that everybody's a little bit different. So it depends on when they would have been exposed to the illness, and it depends on their level of antibody. Sorry, I'm just reading. He's writing extra stuff here. Exposed in April. So yeah, April is a long time ago. So he could have had it in April, and the problem is that we're still learning about the antibody response curve, and it seems that it decreases over time or diminishes over time, but does still allow for some memory effect. So, or they call it the amnestic effect. So basically what that means is that even though someone's immunity, their actual IgG, IgM levels may go down, that if they were re-exposed, their body would recognize the virus again and start to bang out more antibodies at a much faster rate because they already have seen it previously, and then their antibody level would quickly go up. Now, in the case that this question is asking about, I would be concerned, depending on how long they've had myocarditis for. If this was related to COVID, it should have been that they've had the myocarditis for a while, and they still could have a negative antibody test now because their immunity may have waned. And so, especially after the 3-month period, there have already been some studies that show that levels are going down. Yeah, I think it's reasonable for this particular patient that's being mentioned, they're talking about, they're moving on to the echo shows myocarditis, so they're proceeding with cardiac MRI, and that sounds reasonable. So I think that the other thing to remember too is there are other things that cause myocarditis. And so yes, it could absolutely be COVID, and it would depend on more if the patient had symptoms. We don't have reports of patients having asymptomatic disease really and progressing to severe post-infectious problems like myocarditis. It's usually in symptomatic individuals, so getting a good history from that patient would really be helpful. But to answer the specific question, which is what about, can they have a negative antibody test or negative serology and still have been exposed and have post-infectious issues? Yes, they can.
Thank you so much. It's 7:30. I don't see any other questions in the chat box, but does anyone on the call have any burning last minute questions that they want to ask Dr. Witherell before we let her go?
Just wanted to thank you very much. Jesus, when the last time the cardiologist was asking for that question, and thank you for your help. This is a very striking case of that 19-year-old kid who appears to have the problem more so in April with what appears to be a GI issue. He came exposed with fever, chills, and GI diarrhea. For whatever reason, unbeknownst to me, he was not tested, but I mean, presented to me basically, a month and a half ago with continued shortness of breath. And he has seen 2 physicians and a pulmonologist. And I don't know, for whatever reasons, unbeknownst to me, no COVID testing or serological. So I sent him to the county, and 3 times are negative serologically and the PCR. But I mean, I look for, before I would look for zebras, I went for the most prevalent. He was in New York when he came with those symptoms, visiting his brother. And so that's far is negative, but I mean, essentially, the symptomatology, indeed, you are referring to appears to be myocarditis with all the symptomatology, such as discomfort, shortness of breath, deacon exertion, oxygen sats go down a little bit, seen by pulmonologists. He's been put on allergy medication as well as albuterol and rescue inhalers with not that much of that. The fatigue and malaise is very striking in a 19-year previous kid, extremely healthy. And so I'm right now proceeding with a cardiac MRI, but my question is, all the testing that I sent him was in Collier County. The county sponsored a serological test and PCR. All those are negative. My question is, how reliable is, and you explained that very well, and can I have a long haul with an IgG negative as well? Or what are your experience, or what will you, I'm gonna proceed with a cardiac MRI regardless of, based on that compelling data of those 80 patients who were they performed in Europe. I'm sure you're familiar with that testing, as well as with the people in Michigan, from Ohio, sorry, for those athletes that they underwent cardiac MRI as well with COVID.
Yeah, I think that based on the story, the history, I think tells a very clear picture, and I would definitely proceed with testing and treating that case. And he definitely could have a negative IgG now that it's been several months, almost 6 months really since that time period. So he could have a negative serologic test and still have had full-blown COVID. And there are some people that don't end up mounting a large immune response at all, even shortly after the virus. And we see some people, their IgG tapers quickly, but definitely at 6 months, I'm not necessarily surprised that he doesn't have antibody. I'll say that. But based on that history and that story, yes, I would be very concerned that may have been a COVID-related or a COVID illness with a related post-viral syndrome.
Thank you so much. Thank you, Dr. Witherell. I'd like to also thank April Donahue, our executive director, for facilitating the webinar. It's recorded so that others can watch it as well. So I'll thank you again, and I'll wish everyone a very good night.
Thank you. Good night, everybody.
Good night.